Hi, my name is Delo, and today we are going to do the extubation competency. So prior to going to the patient's room, we are going to gather our information from the patient's chart. So we are going to get information from the surgery, or why is the patient intubated, was the patient intubated before, prior to this intubation? Was it a hard intubation or an easy intubation? And how was the weaning process? Was it easy or was it hard? And then after that, we're going to gather the vital signs as well, just to trend. And then we'll see the medications, if the patient is in any bronchodilator or any airway medication, and we'll get that before going into the patient's room. After that, we're going to gather our equipment. So I'll need to have a syringe. Usually the syringe is already on the ventilator itself. An ambo bag in the room, our suction equipment, the young cower, inline suction, um, um, intubation tray, two sizes of endotracheal tube, the actual size that the patient is wearing right now, and a size smaller, and then a nasal cannula, so that the patient would have oxygenation after the extubation, an aerosol mask, just in case we need to give the patient a bronchodilator, or if the patient has a glottic edema after the extubation, we are going to get a racemic epinephrine for that. So after that, I'm going to wash my hands. I'm going to enter the patient's room, so I'm going to knock. Good afternoon, Mr. Francis. My name is Delo, and I am your respiratory therapist for today. You might not remember me, but I've been coming into your room since this morning. You were sedated earlier, so now you're not, and you're breathing on your own, which is really nice to see. Then I'm going to check the identifiers, so the patient's wristband. Just check that. And then I'm going to explain to the patient what I'm going to do in here, why I'm here, and then what I'm going to do. So, Mr. Francis, I'm here to take this tube out of your airway, okay? So you've been breathing on your own for the past hour, which is, you've been doing well. You've passed all your breathing parameters, and you're now ready to breathe on your own without the airway or this tube in your airway, okay? So if there is no questions from the patient, I'm going to start assembling my equipment. So make sure that this one is connected, and then make sure my ambo bag is connected as well. That way, when we disconnect the patient from the ventilator, the ambo bag is ready for hyperoxygenation. And then for nasal cannula, we wanted to put on at least on a 4, so that when the patient is extubated, the patient is having oxygenation. Also, just in case, if the patient is having a glottic edema or anything like that, we want to make sure that the aerosol is connected to the PSI. That way, it's ready to go. So some of the complications, sir, on this extubation is that you could aspirate if there's secretion left out in your oropharynx. We could cause damage if the pilot balloon is not deflated, and then glottic edema is one of the complications that's it's very common to happen. So I would just want to make sure that you know those complications, and that I will do my best to prevent all of those to happen. So if he's fine with it, then we'll go on with the extubation process. So My partner Daniel will be hyperoxygenating the patient. So I'm going to disconnect the patient on the ventilator, then hyperoxygenator. Thank you. So while he's hyperoxygenating the patient, I'm going to suction orally to check the gag reflex. So we go on the oropharynx, going all the way to the hypopharynx to check the gag reflex, as I said earlier. So just gonna suction, then make sure that we put it in there to check the gag reflex, because sometimes the patient is awake, but if they don't have a gag reflex, then the patient is not ready to be extubated because they can protect their own airway. So at this point, let's just say that Mr. Francis has some gag reflex, so he is good to go. So I'm just gonna suction you in line, okay? Make sure that there's no secretions in there, or there's not much secretions left when we extubate you. So if there's a lot of secretion, we could do this multiple times, and then after doing an inline, we could suction again orally. Because they're awake now, so they produce more saliva, especially when they're, having that reflex. So after that, I'm just going to put the towel here. I'm going to put a towel on your body. That way, when we extubate you, your gown is not gonna be soiled up, okay? So after that, I'm going to check my cuff. Pressure, make sure that I could hear any air movement. So we just deflate it a little bit. Usually you could hear it right away, that there's air. And if not, then we could place our stethoscope on the neck area to hear any air movement. So after that, we're going to inflate it again, because we don't want to left it deflated while the tube is still inside the patient's airway. So after doing that, we're going to ask the patient if they could lift their head so that we could take out the securing device. So I'll just take this out. Lift your head a bit more. Okay. And then since this pad, the cheek pads, has a lot of stickiness into it, the patient might feel a little some pain stimulus from us taking the cheek, sticky pads on the cheek. So we'll just let them know that it could happen, and they might feel a little waxing feeling into it. So as of this point, my partner Daniel knows what to do. So he held the tube in, or if the patient, my partner doesn't know how to do it, then I'll just tell them to hold the tube. That way it's still secured and it's in place. So it's hyperoxygenating. I'm just gonna place the nasal cannula on. That way when we extubate the patient, he is receiving some oxygenation. So we'll just put it in top right now, and then we'll fix it later once we've pulled the tube out. So, Mr. Francis, I'm just going to lift your bed up. That way it's easier for me to take the tube out of your airway. After that, I'll tell the patient that on the count of 3, he'll take a deep breath, and then we'll have him cough multiple times while we're pulling the tube out. So Mr. Francis, on the count of 3, you'll take a deep breath, and then I'll ask you to cough multiple times, okay? While I'm pulling the tube out. And then it's also nice to coordinate with your partner. That way they'll give the full breath or 100% while the patient is taking a deep breath. That way he has a good backup in there on the lungs. Okay, so on the count of 3, give him a full breath, okay? So on the count of three, you're going to take a deep breath, okay? 1, 2, 3, and cough, 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 cough. Suction. We need to suction just to make sure that there's no saliva going back in there. So, good job, Mr. Francis. You did well. Just want to make sure that you know that your voice might sound a little raspy or more coarser because your vocal cords are still inflamed. So it'll take a little time for you to actually be able to speak in full or in a louder voice or in a full words, okay? So just take your time and I'll be here with you. So we'll listen to the lungs. Listening. And we want to listen to the neck area to make sure that there's no wheezing, because the wheezing could be an indication of a glottic edema or croup or stridor that's ongoing in there. And we want to listen to the breath sounds to make sure that there's bilateral air movement or aeration in there. So, as I said again earlier, that if they have a glottic edema or stridor, make sure that we administer racemic epinephrine to reduce the inflammation. And then, other than that, that's the extubation competency. Thank you.